Okay, thank you very much, Professor Cam. Well, most of my patients are pediatrics, and I've actually only come to get interested in elderly patients because of structural heart disease. Okay, and this is what we're trying to prevent. And what we would really like is anticoagulant-free protection from AF attributable cardioembolism. There's a huge amount of it about. If a third of Danish women are going to get to 100, there's going to be even more of it about. Certainly it is a disease of the aged. This is the incidence with age from the Framingham study. This is looking at prevalence, and you can see that 3 to 5% of the population older than 65, and 1% in the general population, and 15 to 20% of ischemic strokes, 5% per year in terms of risk of stroke, and at least 100,000 strokes in the US alone. And if we look at the demographic time bomb, and this is just from pension data, we can see the massive amount of people we're going to have in Europe over 80 by 2050. Some of us will or won't be around for it. But if we look at atrial fibrillation in this group, in fact, in the US, from about 2.3 million, it's going to go up to 5.6 million by 2050, and 50% of these patients will be over 80 years of age. And I think the proportion of elderly individuals is going to go up because we're going to have more people surviving with conditions which predispose to atrial fibrillation, not less. These are the risk factors in stroke. We've been through these earlier. I mean, there's good evidence from all this data reviewed in this meta-analysis that warfarin works for preventing stroke in these patients. Aspirin doesn't really help much. The elderly from the BAFTA study, they benefit just as much, if not more, from having warfarin. There is a narrow therapeutic window. We're all aware of this. But we're equally aware that patients, despite the risk of bleeding, still do better from being anticoagulated, and that their strokes have a better survival if they're better anticoagulated at the time they come in for the stroke. Nevertheless, despite this, not that many people who should be on it are on it, so at least so we think. This was a recent look at what they call aged care facilities. I think we call them nursing homes. 9% of residents with atrial fibrillation had a contraindication, but 81% of residents were eligible for treatment with warfarin according to their CHADS-2 score, but only 38% were prescribed warfarin, and mostly that seemed to be the older, once the patients became older, that they didn't get warfarin. And look, this is admission with stroke, and these were patients with atrial fibrillation, known to have atrial fibrillation, who were meant to be on or could have been on warfarin, and only 10% were on therapeutic warfarin. The vast majority were either subtherapeutic or on an antiplatelet or nothing. When you look at people who have atrial fibrillation and a previous stroke, when they're readmitted with a stroke, you find 18% with therapeutic warfarin, the majority on either subtherapeutic or nothing. So reality in practice is very different. These were some of the recommendations when warfarin was still considered to be a treatment for it. Maybe the ECG monitors should have a warning on them saying the patient should be considered for anticoagulation. Maybe the pharmacist should flag the patients, and lots of decision aids for patients and physicians. This is sort of the pathophysiologic or pathogenesis thing that we're meant to be working against. I think what's really interesting, though, is, in fact, I think this may be the only case where someone saw a thrombus going from the atrial appendage and the patient had a stroke later on. I suppose the coincidence is maybe difficult, maybe it's a low probability of happening, but it's interesting that there's just one set of pictures in the literature of a thrombus disappearing from the left atrial appendage and the patient having a middle cerebral artery occlusion later on. We have this information with most of the thrombus being in the left atrial appendage, 90%, but you still only have 10 or 15% of people who have atrial fibrillation having a thrombus in the atrial appendage. So this was the basis for Plato back more than 10 years ago. But the problem with the left atrial appendage technique, and particularly where elderly patients are concerned, has been hemopericardium. And this is probably the same for pulmonary vein isolation. There's a small This was 8%, late embolization 1%, puncture site problems, but the results were good. You know, they did expect, you know, 5.3% strokes a year, but just got 2%. And this was the same when they're looking 6.5% expected stroke, actual of 3.2%, so suggesting it may prevent stroke. So it was the first, first sort of somewhat evidence, non-randomized, of course. Here comes Watchman. Pilot, again, safety problems. Good endothelialization, but thrombus on devices. Problems with implanting the device too distal or non-aligned with residual flows. From the pilot study, 1.9% anticipated stroke, but 0% at follow-up. The PROTECT AF, we've gone through this in terms of it was a non-inferiority. These were the safety event problems were the main trouble with this, and mostly procedural pericardial effusions, but you can see 48 device events versus 13 control events. A lot of peri-procedural stroke. If we were to look at really the end conclusion, which is all stroke, we have a relative risk of 0.74, but with very wide confidence intervals of 0.36 to 1.76, so it could be worse on those confidence intervals. And this is related to the fact that ischemic strokes were higher in the device group, 14 events versus 5 events on warfarin. And also, and I think what allowed the study to achieve non-inferiority is that there were 6 hemorrhagic strokes in the control group and 1 in the device group. So it's sort of really a sort of an ungenerous conclusion to PROTECT AF, which was a wonderful randomized trial in terms of device therapy, is that warfarin is dangerous. Look at the learning curve. We can see that there is a big learning curve effect in PROTECT AF with the continued access registry showing serious pericardial effusion dropping to 2.2%, procedure time dropping, device embolization dropping. So this is very encouraging. But it gets down to the pathophysiology of stroke in atrial fibrillation. Do we believe it's as simple as stasis and left atrial appendage thrombosis? These patients are very complex. They have a huge atherosclerotic burden with complex aortic plaque, and there's a massive systemic prothrombotic state. And the neurologists, this was Stuart Connolly's group, looking at the PROTECT AF study, writing in Circulation, says that left atrial appendage likely accounts for much less than 90% of stroke suggested by the ECHO studies, and the efficacy of LAA occlusion therapy for stroke prevention AF will depend on the proportion of strokes that are actually caused by left atrial appendage thrombus. And they felt that uncertainty surrounding the pathogenesis of stroke in AF needs that we need well-designed trials before it can be accepted. And then they moved on to say that Meisel has pointed out that the trial is too small to conclusively claim non-inferiority to warfarin, reflected by the wide 95% confidence intervals, 0.36 to 1.76, and a definitive randomized trial is indicated. Of course, that will be ongoing, hopefully. David Holmes got an opportunity to reply to this. They've started with the warfarin problems, which are all agreed, and that you have catastrophic complications can occur most frequently in the elderly, the very population that needs it most. But he agreed, PROTECT AF certainly provides very useful. I don't think it's a complete answer, but he agreed that it should be tested further. So the Amplatzer plug, we got it in December 2008. We're all aware that it's basically a top hat closure of the orifice of the appendage. This was an observational study that we reported recently. 206 patients consented. 2 were screen failures, they had thrombus in the appendage. 204 patients enrolled. We failed to implant in 7, and the device was withdrawn in 5. Device implanted in 197, and 183 have got to a 6-month follow-up. So really, the success rate of implantation was really very good. You can see this is a very elderly population, 73.7 years as their mean, with relatively high CHADS-2 scores, many with 4s and 5s. The indication, pretty old bleeding risk, and only 4% of the patients were on active anticoagulant therapy at the time of enrollment. So it's not a warfarin alternative. These 96% success rate in terms of implantation. Most people got the first device, and good closure rates and closure rate defined as residual flow less than 3 millimeters. Only 1 patient with residual flow at 5 millimeters. The main problem, again, with the technique is safety events with 3 serious pericardial effusions, 3 device embolization. In fact, one of the pericardial effusion patients had a device embolization as well, which was detected at day 86 and was removed by snare. There was 1 death in the pericardial effusion. Probably was not a significant pericardial effusion, but therefore it got graded as a serious pericardial effusion, and 2 deaths in the embolization related to surgical retrieval. So the device embolizations, as always, occurred early in the learning curve. There was later on device-related thrombus, which is similar, 2.4% similar to PROTECT AF. And if we can compare to the original post-market observational study, which was only looked at 24 hours, the safety event rates have come down from 7 to 2.9%, looking at if you exclude the device thrombus later on. And if we were to look at stroke in this group, most patients had, 38% of the patients had a previous stroke. And we would have expected, doing their individualized CHADS-2 score, would have expected 5.6%, but only got 2%, which is reassuring. And patients pretty much got off their, a lot of them got off their Plavix and are just on aspirin at the end, at the 6 months. But anyway, all this is all very good, but the goalposts have been moved. We have Relay and dabigatran, anyone who can afford it should be on it. It's superior in most aspects other than its GI aspects. We even have our geriatricians, one of my colleagues who works in the same hospital, writing into the Irish Times in April saying that nursing home care costs $50,000 per annum for stroke. If you switched 50% from warfarin, you would prevent 175 strokes per annum, with 100 less needing nursing care and saving €5 million in the first year. When I spoke to him about atrial appendage, what we thought he'd save with that, he really wasn't able to give me an answer. He referred me to people who might do some calculations. But like all these things, drugs, I think all of us will remember this from Lawrence Clinical Pharmacology. The book has gone through many, many editions. I don't know where we are with the new oral anticoagulants in this curve, but I think we're somewhere, that it's probably in carefully selected patients. We may be getting close to that. Here there's lots of case reports appearing on these new drugs. Here's a spinal case report suggesting that if you had an epidural hematoma on the spine and the patient was on a new oral anticoagulant, you wouldn't want to operate on them. You would want to delay operation until they get in. And clearly removing a pressure hematoma from the spine is a major emergency, and delaying it is not going to be good for the patient. And we're seeing these sort of things appearing. 117 US deaths from Pradaxa. I'm sure you'd have the same number of deaths from warfarin, but just Pradaxa's new. The attorneys clearly view this as a good chance for a class action, and multiple lawsuits have been filed. In terms of recommendation for our patients, NICE gives some guidelines, but a risk of life-threatening complications, and you need people with appropriate experience. The past ESC guidelines from Professor Cam says it's there as a treatment, 40% of cases with residual shunt. Residual shunt looks like it may not be significant, but obviously we would much rather it not be there. This is some Watchman results. In terms of a recent review in heart, again asking for a well-designed randomized control trial comparing occlusion with warfarin alternatives, on-site surgical facilities, and multidisciplinary team selection. So which patients benefit most? Well, those at a high risk of stroke and those at a high bleeding risk. So that's the elderly, I think, pretty much. There's going to be exceptions, of course. And we can see the overlap, and we've had this earlier, between the CHADS-2 VASC and the HAS-BLED score with hypertension, stroke, and the elderly in both groups. If we look at the role of major hemorrhage on warfarin, this is looking at when you start warfarin off, and this is the main problem, is usually the first 3 months that they start. And if you look at the aggregate hemorrhage rate, 7.2% in this study for an inception, that's in the first year, 13% for patients more than 80 years of age, and then 26% of the patients greater than 80 years taken off warfarin due to safety concerns mostly. So when is it contraindicated? It's difficult to know, but these are some of the things. But inability to have INR determinations and difficulties with hearing, vision, or numeracy become commoner and commoner as people get older and older. This is a patient, we had some very interesting case reports last time. This is a patient, this is a thrombus in the left atrial appendage. It's not a Watchman device, it's a thrombus. There's a previous subarachnoid hemorrhage on warfarin, previous cerebellar hemorrhage on aspirin. These are the Chad's VASC and has-bled scores. And how do you deal with this patient with a thrombus in situ? This isn't such an uncommon problem. We know that left atrial thrombi can dissolve slowly if given time on this Kaplan-Meier graph. We know we can restart warfarin in patients after intracranial hemorrhage, sometime between 10 and 30 weeks. There's an optimal crossover time. If we look at warfarin underutilization, which is the key thing, they said, well, when you look at the studies, it says that warfarin is terribly underutilized, but when you actually do detailed chart reviews, you find the inappropriate underutilization rate was only 7.1%. I think the truth is obviously somewhere in between. If we look at more patients receiving stroke prophylaxis, if you look at the higher CHAD scores, that you can see the higher the CHAD score, the less warfarin you get. And that's because of other problems like dementia, inability to cope with dose adjustments, all these sort of things. The interruption of anticoagulant therapy, a big problem. Patients, as they have more comorbidity, as they get older, they get more and more done in modern medical systems, so they have to come off the warfarin regularly. Often it is stopped for not very good reasons. I think EP doctors have learned that it's safer to do the implant on warfarin these days rather than try bridging strategies. So we come to the economic argument. So increasing demand, shrinking health budgets throughout Europe. So we need to utilize our resources, remaining resources well, by the best clinical evidence. This is a Canadian study looking at LAA occlusion, costing it the same as an ASD occlusion, and something like $40,000 for someone with a CHADS-2 score of 2.5. Whereas if you go up to CHADS-2 scores of 3 and 4, in fact, for a CHADS-2 score of 4, it only costs $6,000. Well, that's one of the cheapest qualities that you can get. But if you need that, assuming it's cost effective, you need, what we really need to establish left atrial appendage closure, particularly in the elderly, is a contraindicated randomized controlled trial where we have an adjudicated committee deciding that the patient truly is unable to take oral anticoagulants in a reasonable way. There's a combined stroke and death efficacy endpoint and a cost effectiveness assessment. So to conclude, atrial fibrillation is mainly a disease of the elderly. Thromboembolism from the left atrial appendage is one of the main causes of stroke in AF patients. LA occlusion potentially targets the main source, particularly important in elderly patients with contraindications to anticoagulation. The rate of procedural complications from the technique needs to be very low, particularly in fragile elderly patients. A randomized trial of LAA closure in these patients with adjudicated contraindications to oral anticoagulant is what we need to take this therapy further forward. Thank you very much.
Thank you very much, Kevin.